Who's me, you're saying? Well, if you're on Facebook, you can see the text on the screen because I got fancy pants software which says that on Facebook. Instagram doesn't know what I'm on about because I don't know. Can you get scrolling things on Instagram? If you do, I want it. All right. I want it. Oh, you know what? I got photos and I showed the photos on Instagram last week, but I haven't set it up this week. Oh, dear. Amateur. Anyway, this guy right here, if you're wondering, if you're new to the show, is Jonathan Staiano, plastic surgeon extraordinaire, and he's here to answer your questions. And if you've got a question, then just post it, or well, that's it. Post it. I don't think there's no ifs, no buts. Just post it, yeah. But if you haven't got a question, just sit back and listen to these questions right here, because I've got a list of questions, and I'm going to start with this one, if that's okay with you. Okay. Can you remove birthmarks through excision? Yeah. Is there another one? Yeah. I find it. Can I just say, I'm going to assume every audio and video. I don't want to say that every week. Let's just assume that the audio and the video is working, shall we? Let's going to make that assumption. I find it, maybe weird's the wrong word, but I find it obvious when people say, can you remove this through excision? Can you remove that through excision? This mole, that mole, tattoos. A lot of people say, I didn't realize you could remove tattoos by excision. All is well, says Khan. Someone's listening. Okay, that's what we need. That's the sort of interaction we need. Now, I've got to be honest with you, Instagram's good because you've got lots of waving. There's a lot of waving going on Instagram, which I'm very grateful for. Facebook, not quite sure, but Khan has said all is well. So Khan, thank you for that. Someone apart from these people on Instagram as well is that it. Right. Oh God, where's my question gone? My question is gone. Yeah, I find it weird when people say, can you remove this through excision? Can you remove that? Can you remove a birthmark? We had one the other day, can you remove a cherry angioma? I hope that's not on the list of questions. Hope I haven't stymied one of my questions for later on. But basically, you can remove anything. I mean, you can cut a bit of skin out. You can cut any bit of skin out. The thing about the cherry angiomas is they're often quite small, so it's not really worth cutting things out. So often, sometimes you might want to go and see a dermatologist for some advice if you have got a condition. And actually, there is one later on in the show where someone might want to see a dermatologist. Keely's here. Keely, good to see you. But you can remove anything. So birthmarks, yes, birthmarks are, but the thing about birthmarks is they can range. So what we normally say to people, to be honest with you, we say this for most things with tattoos and moles and cysts, if you can send us a photo is usually the thing to do. So I can have a look at it, give you an idea of whether it's possible, and if so, what it would involve. But the simple answer is yes, you can remove birthmarks through excision. But a bit like the tattoo, or a bit like anything, depends on the size and the location. So if it's a huge birthmark, over your face or something like that, then that's gonna be a challenge / impossible. But if it's a small birthmark somewhere where there's some skin laxity, then yes, it could be removed by excision, although it would leave a scar. That's the thing about removing things by excision; they will leave a scar. So you have to balance that scar with the against the benefits of having the lesion or the mark removed, because particularly if you're doing it for cosmetic reasons, you may be unhappy with the thing that you've got, whether it be a birthmark or a tattoo or a mole. But then what we don't want to do is trade it in for a scar and make you unhappy with the scar. So we've got to make that balance that you're going to be, find the scar preferable to the thing that you've got, whether it be a birthmark or a tattoo or a mole or whatever. So, but yeah, simple answer. And long dragged it out a bit, but yeah, a birthmark can be removed through excision, depending on the size and location. Send us a photo, info@staianoplasticsurgery.co.uk. It's a long address, I know that, but what can you do? What can you do? Ida says, good evening. I'm going to say good evening to you, Ida. Nice to see you here. And here is a questions. Oh, this is a classic, isn't it? It's a classic question. Why don't we? Yeah, I want to be a double D cup. What size implants will I need? Classic. That's a classic. That is. Well, I don't know. Simple answer, I don't know. And I don't go on cup size. And the reason I don't go at cup size is that everybody out there could wear the cup size bigger or smaller than what they're wearing now just by changing the back size. So if you're a 32B, you could wear a 34A. Maybe I should have said 32C, 34B. Might have been sounded better actually. But yeah, if you're a 32B, no, I shouldn't try and take on complex equations this late at night. I should have had it written down. If you're a 34B, you could be a 32C. Okay, I think that's quite clear. Bigger cup size, smaller back size. You know, you could probably wear a bigger cup size and a smaller. That's the bottom. That's a better way of saying it. Can we just cut that last bit? Just cut it and then start from here. If you could always wear a bigger cup size and a smaller back size and just change your cup size with the breast that you got now. That's the point. So it is not a set thing, a cup size or different makes. Sometimes people say, when I go to this shop, I'm a this cup size. And when I go to that shop, I'm another cup size. So it does depend on the make and it does depend on the backside. So backside? Did I just say backside? Cut that as well, please. So it is not a precise science. So if someone says I want to be a double D, it's like flipping neck. I cannot guarantee that. So what we do in terms of the implants is we have sizes in the clinic, which are a bit like chicken fillets. They're like external prostheses and we know the volume of them. So that's better than saying I want to be a double D. We give you these sizes. We say, look, that's a 150cc, that's a 250, that's a 300, that's a 400, whatever. That's 300 cc's of volume. You try that in your bra. What does that feel? Does that feel like a good volume? And if you say yes, well, we say, okay, well, that's the sort of volume we're looking at. We're looking at 200 to 250 or something like that. That's the volume we're looking at. And then we've got to look at the shape and the profile, which is actually more important than the volume. Shape and profile is everything, really. Well, width is everything. Anyway, there's those three things, really, in terms of choosing an implant: the width, the shape and the profile, and the volume. And actually everyone worries about the volume, and actually the volume is the least important out of the three. The most important is the width, and that is a set number. That's the width of your chest. Then shape and profile. Once you've got, your width is set, once you've chosen a shape and profile of implant, that will then lend itself to a certain volume. So that's how I go about choosing implants. And I don't start with the volume, whereas when someone comes to the clinic, they always start with the volume, say, what size implants do I need to be a double D and all that. So that's how we go about sizing people for implants. It's all about the girth. If you like Sealy, yeah, it's all about the width. The width is absolutely crucial, and I think that is how you get a good result. You get the right width, and you particularly don't want to go too wide. In my practice, that's how I do it. All right, calm down, Instagram, flipping heck. What kind of crew we got on Instagram here? Right. Yeah. So in answer to your question, whoever, I don't know who asked the question, but whoever wants to be a double D, can't guarantee it. Try the volume sizes, and then we can give you that volume, and then hopefully be the cup size you want to be. But I'm going to be fair disclosure, I get it wrong all the time in terms of cup sizes. People say I want to be a D, and I'm like, okay, that sounds reasonable. Try and go through the process, and they come back and they're a double D or something else. I'm like, oh crikey, you wanted to be a D, and they go, no, I'm happy. If you get it right, it doesn't matter what the cup size is. You got to get the shape, the profile, the size, everything right. That's what you got to do. It's not about the size. You just go for the double D and the shape's not right, or it doesn't look right, you're not going to be happy. Whereas you get the shape right, you get a good look to your breast, the right, the right fullness, the right shape, the right profile, the right width, you're going to be happy. So that's the way to go. Could do a whole thing on that, but I'm going to curtail myself. We have got someone using the hashtag fourth comment in, guys. Fourth comment in. We got the hashtag being used. Hashtag Ask JJ. That is the sort of publicity we need. Well done, Liz. Big up yourself. Yeah. High five. Boom. Right. Sorry, I saw someone do that the other day. I thought it was great. Instagram, high five. Yeah. Boom. I'm gonna steal it now. It's gonna be my thing now. I'm gonna do that. High fives. Issa is here. Boom, Issa. High five. Wave at ya. Right. Is it necessary to have drains with a tummy tuck? The idea of having them makes me queasy. Thinking about carrying them around and then being caught accidentally. Oh my lord, that makes me queasy too, Liz. Good question. Very good question. No, I was about to say no. Is it necessary to have drains? Well, let me answer a different question. Is it essential? No, it's not essential, and there are people out there who don't use drains. And I've got to be honest with you, Liz, the movement in the plastic surgery fraternity, there is a movement away from drains in general, and personally, I'm moving away from drains too because people don't like them. The idea makes people queasy, they feel uncomfortable, they don't like having them removed, and people don't like them. So if you can not use a drain versus using a drain, if you say to someone, do you want a drain or not? The answer is always not, or everything else being equal. So there are people out there who don't use drains, and I think it is very appealing not to use drains, but I do use drains. So is it necessary? No, because people don't use them and they have good results, so that's fine. So, but do I use them? Yes, I do. So it is necessary in my practice, but not necessarily in everybody's practice. And the reason I do use them in a tummy tuck is because there's a dead space there. And I use suction drains. You don't go home with them. You only have them in for one night, maybe 2 nights. So you don't have them in for long. But I do think they are good. And I'm now doing quilting sutures to close down that space to reduce the drainage, to reduce the need for drains. And it might be that, watch this space, I might not use drains in the future, but I do at the moment. So, but I don't know. We're all moving away from them, and I think the idea makes a lot of people queasy. But as I say, you don't have them in for long, 1 or 2 nights, and I still think they do serve a good purpose personally. Lisa Wicklin is in the house. You got it spot on with me. Very happy. Lisa, calm down. It's early days. Calm yourself down, Lisa. Calm yourself down. But I'm very grateful for the comment. I'm just going to leave it on there. I got it spot on with Lisa. All right. Thank you, Lisa, for that. And hope you're okay. Hope you're all right on the journey home and everything. So that's good to hear. Yes. Yes. Winner. Ring the bell. Haven't got one. Right. Just let everyone see that. Got it on spot on with Lisa. Good, Lisa, because we went over it quite a lot, didn't we? So that's good. I'm glad we got it spot on. And I thought it was spot on as well. Tanisha just joined. What does it mean to have the implant under the muscle or over? What's the difference? Good. Oh, and then look at this. What's Tanisha done? She's come back on with the hashtag. Yeah. That is what I'm talking about. Tanisha, I salute you. Do you know what, Tanisha? People getting really into this breast implant thing. To be honest with you, people getting really into everything with the internet. They get into it so much. And it's arguable whether, I suppose it is a good thing that people are informed, but they do. Sometimes people get really down into the sort of minutiae and into the this and the that and the, oh my Lord alive. So the muscle thing, the bottom line, Tanisha, I won't worry about it too much, is my advice. It is a bit of a technical thing, but since you've asked, I will answer the question. But there's a lot to think about in terms of implants, size, shape, type of implants, there's all different types. But in terms of the muscle refers to the pec major. The pec major is a big muscle going along here. I would show you, but I'm not sure. Facebook might shut me down with / Instagram. Let's not forget Instagram. I think Instagram will be all right with chest, isn't it? It's Facebook that shuts you down. Mind you, they're the same now, aren't they? But anyway, I would show you on myself. But on the bodybuilders and stuff, the pec major, big muscle comes across here. So under or over the muscle means under or over the pec major, this big muscle here. And there's good and bad about both. That's the thing, so you can't just say one's better than the other. And so the good thing about putting them on top of the muscle is hurts less, bleeds less, recovery's quicker, and also the implant sits with the breast tissue, so it's on top of the muscle. That's good. When you put it under the muscle, hurts more, bleeds more, recovery is a bit slower. And also, the muscle can sometimes hold the implant up high. Sometimes the muscle can hold the implant wide. And sometimes you get animation deformity. So if you do the gym and what have you, the breast can move because it's underneath the pec major muscle. So every time you flex the pec, the breast moves because the implant's underneath it. So that sounds like it's bad for the muscle thing. So there must be something good about the muscle thing. So the good thing about having it under the muscle is the muscle gives it an extra layer of cover. So if you're very slim, particularly if you can see your ribs, if you're very slim, then you worry if you put the implant on top of the muscle, you'll be able to see, maybe able to feel the implants, maybe able to see the implants, maybe see ripples. I don't know if you've ever seen rippling of the implants. Sometimes if you look at an implant, you hold it up, often it ripples. And the question is whether you can see that through the skin. And if you can see your rib cage not through the skin, but if you can't hide your rib cage, I always say, look, if you can't hide your rib cage, you're probably going to be able to see the implants. So that's why putting it under the muscle can be helpful. So that's the good thing about putting it under the muscle. It does hide the implant better, but it just hides it in the upper medial quadrant here. Here is not under the muscle. So that is always not on top of it, it's always sort of subglandular. So you might get ripples laterally on the side, but it does help it in the cleavage area, which is a cosmetically sensitive area where you don't really want ripples here. So that's the good thing about putting it under the muscle. So yeah, there was something I was going to say about that, but they're good and bad, Tanisha, good and bad about putting it under the muscle. And it's a question of balancing it up for your particular case. I have shaved this morning. It doesn't look like I have, does it? Flipping heck. So yeah, good and bad with the muscle thing, Tanisha. Good and bad. Also, Tanisha, you can get animation deformities when I've said that already. Oh God, I'm losing it. I think I should do this earlier on. Anyway, yeah. So that's the muscle thing, Tanisha. Under or over, which is best? Who knows? So next question, please. Oh, hold on a minute. There was something up here, wasn't there? Sorry, Instagram. I'm neglecting you. All about the girth. Can you remove skin and make me look good? Right, Seeley. Okay. Right. Nice use of the Ask JJ hashtag, so I'm going to commend you on that. Can I remove skin and make you look good? I don't know, Seeley. That's a hard one for me to answer without seeing you and seeing what skin you want removed. I can remove skin, and I can trade that skin in for a scar. And so the question is whether the scar is going to be preferable. So if you have got redundant skin somewhere, classic places are the breast, saggy skin on the breast, tummy, arms, thighs, face as well, but I don't do facelifts. But they're all doing the same thing, removing skin and tightening the skin to make it look better. But it might be a possibility, Celia, a bit hard to say without seeing you and talking to you about the pros and cons. That's what it's all about, pros and cons. Weigh it up, people, weigh it up. Hold on a minute, what's this question? Okay, what's the difference between full and circumferential abdominoplasty? Well, in simple terms, a full abdominoplasty just addresses the front of the abdomen. So when you're lying on the operating table, we take the excess apron from the front of the abdomen, which is always the worst place. It's always, even when you've have a circumferential, the front is always worse than the back. So a full abdominoplasty takes the whole excess skin, the abdominal apron from the front, and gives a scar from hip to hip. A circumferential abdominoplasty carries that on and goes all the way around to the back. And circumferential abdominoplasty is much less common than a full abdominoplasty. It's a much bigger operation than a full abdominoplasty. It requires you to be turned during the operating theatre while you're asleep, which is always a big deal. And it also has much higher risk of complications because you're tightening the front and you're tightening the back. And for me, the real benefit comes, yes, it does tighten the back, and sometimes people feel that they have excess skin on the back, but it's quite modest, the tightening of the skin on the back. For me, the real difference or the real benefit in terms of the circumferential is the sides, because if you look at the skin that we remove with a full abdominoplasty, it's like an ellipse. So it's very high at the middle. It goes from your pubic area to above your belly button. All that skin gets removed, but then it peters out to the side. So we take it out as an ellipse so we don't get dog ears when we close it. When you do a circumferential abdominoplasty, it peters out a bit, but it stays quite high and it goes all the way around. So the amount that you remove on the sides with a circumferential abdominoplasty is like that, and with a full abdominoplasty, well, it's basically nothing. So it's a much more at the sides that you remove with a circumferential abdominoplasty, and it really helps those side bits, those hips, and it really takes skin off those hips. But it's a significantly bigger undertaking, and so it is really something that you've got to think about. Now, Cheryl Michelle sent a request to be in your live video. View request. Listen, Cheryl, I think in my experience, people have done this erroneously. If I say yes, it will link to your camera and you'll be on live with me. So I don't think, is that what you want? I mean, you can come on if you want, as long as you're not going to swear and stuff. But in my experience, people have done that by error. But if you want to come on and ask me a question live, that'll be a new dimension. I think that's a game changer. That if people want to come on live and, you know, proper talk live. I don't know if you can do that on Facebook. I'm not sure, but you can do it on Instagram. So if you want, Cheryl, say yes, I want to talk to you, and I will do it. Let's do it, girlfriend. But I'm going to wait, because usually people are horrified to think they might be on the camera and, you know, live to the nation. Because Cheryl, I warn you now, if you go live, there's a lot of people out there watching this. I mean, we've got 4 people, Cheryl. So all 4 people will see you, the whole, you know, those 4 people in the nation. No, you don't want to. Oh, okay, there you go. Yeah, it was that fame. Yeah, I know you didn't want to. It'd be on the news before you know it. 5. Look at that. The numbers are going up. Oh. Social media influencer right here, sitting right here. 5 people. You want a message? Tell me. I'll get it out to the nation. Right. What we got? What's going on? Tanisha is laughing. Thank you. That was helpful to know. Thank you, Tanisha. Very, very welcome. Why are my cysts not suitable for surgery? The cyst is under my chin, but it's very large and visible. And now, due to this cyst, there are smaller cyst spots forming around the area. I've previously seen a dermatologist. They prescribed medication that did not work. The GP has recommended a private cyst removal. Okay, so let's show in the stream what we got. I believe that is a chin. Is that the same photo? Yes, it is. Okay. Hide. We can rotate it. Anyway, let's not try and get too fancy. Can you see that? It's a cyst here. Right. I love your accent. Have I got an accent? Cheryl, have I got an accent? I didn't think I had an accent. Have I got an accent? What accent have I got? Right. Instagram. There's the cyst. People, I'll tell you what, I can rotate it, can't I? That's what I should do. Rotate it. Oh, crap. No, I can't rotate it because I've got my case on. God. Right. Can you see that? You see that? So maybe you can't see it. I don't know if it works or not. Anyway. So this patient has got cysts here on the chin, and they've got other cysts around the area. And what I've said with this patient is that I think it would be better seeking a dermatology opinion. I've got to be honest, I said that before I knew she'd had a dermatology opinion, because it looks like acne-form skin. It looks like there's acne in the skin, and when you get multiple cysts, particularly if there is acne in the area and subacute infection, by subacute I mean not sort of raging red and angry, but just grumbling infection, it can be difficult to sort of cure that problem by removing the cyst, because the problem is not the cyst. The cyst is a manifestation of the problem, and so you really need to get behind what the problem is. So I would, to be honest with you, I would stick with the dermatologist personally. I can definitely remove that main cyst. There's one main cyst and there's some around it. I probably wouldn't remove all of them. I'd remove the main one, but there'd still be other ones around it. And if there's other cropping up, if you haven't cured the problem, you're going to get more. So you can have a scar with, some other cysts around it. And also, if it is subacute infection, when you do this sort of surgery in patients who have acne, you do worry a bit about the wound healing and infection, etc. So it can be a bit of an issue. So on balance, I would look at an underlying problem for there, and rather than just going in and taking the cyst out. Instagram, got to apologise, poor connection. It's saying paused due to poor connection. We're back. I think Instagram, I think we had a flood of people on Instagram there, which just overloaded the servers. Back down to 5, 4 now. Okay, that's good. So hopefully we'll keep the connection stable. We don't want these spikes, when it gets interesting, when this live Q&A gets interesting, we get a flood of people coming in and it goes up to 5 or 6, and that really does overload things. Muscle, really helpful. Right, let's hide that photo, get the big guy back on. It's me, this is Keely, it's me asking about immunosuppressants. Been on mercaptopurine for 6.5 years due to ulcerative colitis. Thanks, JJ. How did you know that was the next question? Wow. Is this you then? I am immunosuppressant. I am immunosuppressant. Can I have surgery? Is that you? Or is that someone else? Okay, Keely, I will talk about your one maybe if it's different to this. So this question is saying I am immunosuppressant. I think it means I'm immunosuppressed, so we won't label that. Can I have surgery during COVID-19? Yes, you can. We are doing surgery, and we have put measures in place to limit the problems in terms of COVID-19 specifically. So this is specifically asking if someone with immunosuppression can have surgery during COVID-19. There's another question to say, should someone who's immunosuppressed have surgery? That's a different question, which I'll answer in a minute, because I think that's what Keely's talking about. So there's one question to say, should I have surgery, period? Assuming you're okay to have surgery, then is there a problem with COVID-19? Well, no, there isn't, because we have put measures in place to limit the potential for contact and for spread during surgery, to both protect ourselves as the healthcare providers and you as the patients. And we do lots of things in terms of keeping things very tight with the PPE, doing COVID tests for everyone prior to coming into the hospital, with only people who are having procedures allowed in the hospital, which is a bit harsh on the relatives, I know, and I feel bad about that. But it's all in a measure to limit the spread. So you're absolutely fine. If you're okay to have surgery at any time, you're okay to have surgery during COVID-19. However, you might feel uncomfortable and you might be worried because of the increased risk around this time because of the COVID-19. So you might wish not to, which is fine. And if you are significantly immunosuppressed and under another physician, you might want to ask them, what they think. So you might choose not to, but we are still doing surgery. I would say as normal, pretty much as normal in terms of patient selection, but obviously limiting the amount of surgeries we're doing and putting extra measures in place. But yes, so yes, you can. Oh, hold on a minute, this is you. I was diagnosed with ulcerative colitis in March 2014. As you can imagine, I'm on a cocktail of medication, one of which is the immunosuppressant mercaptopurine. Oh, here we go. It is you, right? So Keely, let's look. So I also smoke purely to help with my UC. If I stop, I usually start to go into a flare. If I stop what, smoking or the immunosuppressant? So yeah, okay, that's good. Okay, so Keely, so specifically in terms of surgery now, Keely, I'm not sure what sort of surgery, but I guess it doesn't matter that much. When you're immunosuppressed, you are. Oh, Cheryl's got to run, guys. Cheryl, you go and have a good evening. Thanks for letting us know. Take it easy. Sorry we couldn't meet up on this occasion, Join, but thanks for coming. Bye, Cheryl. Say goodbye to Cheryl. Everyone, take it easy. 5 goes to 4 now. I know we're still on 5. Are you still there, Cheryl? We're still on 5, even though Cheryl's gone. Wow. Yeah, that's interesting. So immunosuppressants will increase your risk of infection. Fact. And if you've got a chronic condition, so if you've got a condition, chronic means lasting a long time. If there's an acute problem, so acute means lasting a short time, so acute and chronic in medical terms are different slightly to what acute and chronic are in lay terms, if you like. So we use the word acute to mean short period of time and chronic meaning a long period of time. So if you've got a chronic condition where you're on immunosuppressants and nothing's going to change, then we've got to make a judgment. If you have an acute flare up, for instance, and maybe if you're a bit up and down with your inflammatory condition, then we would say, look, let's get it stable. So you don't really want to have surgery if you're maybe having a higher dose of immunosuppressant than you might be having in 3 or 6 months or in a year. So if there's any chance that things are going to get better in the future, then fine, then you're better off waiting. But if your condition is chronic and it's just like this for a long time and you're stable, and again, we would ask you to talk to your gastroenterologist, or we would talk to them if you wanted. We would write to them to say what do they think, and whether there's anything that they need to do to optimize your medication. So that's the first thing. Your medication needs to be optimized. What do we know what the surgery is? So whatever the surgery is, let's say it's some kind of, I'm not sure what the surgery is. So let's say it's some kind of body contouring procedure, like a breast lift or a tummy tuck or something like that. One of these procedures where you're closing skin tight. Smoking is a disaster. And I understand that it helps you with your condition, and it might make your condition, oh, here we go, breast lift. I stop smoking. Okay, so I understand that smoking might got it, Keely, breast lift, so might help you with your condition. But from a surgical point of view, smoking and a breast lift is a disaster waiting to happen. And it's not like I've got it in for smokers or anything like that, but I say to people, if you cannot stop smoking, then don't have a breast lift. It's that bad. So if you cannot stop smoking, or rather if you sort of don't want to stop smoking because your ulcerative colitis is going to get worse, I don't mean don't want in a sort of, I understand that it makes your condition better and that's what you're worried about. You're going to get a flare up, but it's just not compatible in my view with having surgery. And it's just a question of managing that flare up, whether I don't know what to say about that. And again, we probably have to seek help with your gastroenterologist with that, or whoever's looking after your condition to try and work something out. But you really need to not smoke if you are having surgery like a breast lift, because the wound is closed under tension. And if that wound doesn't heal up, it can be catastrophic. And smoking is bad. I mean, it can happen even if you don't smoke. And you're throwing into the mix the fact that you're immunosuppressed, so that does increase your risk of getting a wound infection, which again can be bad with a breast lift. So there's no question, Keely, that you're putting the odds, sort of against you in a way compared to someone who hasn't got the same condition as you. And there's no question you're increasing the risk that you might get a problem. Fact. And I guess it needs a discussion, because you might say, forget it, mate, not having that. If I'm going to get all these problems, my breast lift is not that necessary, so I'll just stick as I am. And I'm like, well, then that's probably a reasonable thing to do. Or you might say, it's ruining my life, I don't care, even if I get an infection, sort of thing. In which case you might want to go ahead. But it's a difficult one, Keely. I don't think there's any answers, and it just needs to be weigh up the pros and cons between yourself, us, and the person who's looking after your ulcerative colitis. But it's a tricky one, that, Keely, tricky one. And they're definitely, negative factors, if you like, or factors which would increase your risk of complications. Immunosuppression and smoking. And for me, smoking is a absolute contraindication to surgery, really. So I hope that's helpful. I'm happy to have more of a discussion about it. Tanisha, I'm not sure if I could ask this, but how do you prepare your patient that is having extreme anxiety about being put to sleep? I'm asking as I'm wanting to have breast implants and tummy tuck. I'm really excited, but I'm feeling very anxious about being put to sleep. Yeah, we do see that quite a lot, Tanisha. And I think everyone to a degree is anxious. And obviously some people are more anxious than others. And I think you prepare them by, if there's a few things you can do. One thing is put them first on the list, because I think one of the worst things you can do is come at 8 in the morning and then, have surgery at sort of 5 o'clock in the evening, then that's not helping anybody, which we try and avoid doing for anyone, to be honest with you. But that's something that we would do. And one of the things we do, we've done some cases today which patients were quite anxious. And I think what I try and do, and I think what most the rest of the team try and do, is try and make it a bit more routine. And try and, obviously it's a massive thing for you, and that's a massive op you're talking about there, breast implants and a tummy tuck. But we try and make it like just another day in the office. We're just going to do this and we're going to do that, and then we're just going to, it's just a day. Let's just, try and treat it as a routine thing, which it is for us. Obviously, it's not for you, but to try and make thought, it's a big deal and all that. I mean, we'll go through all the big deal stuff in the clinic. I'll tell you all the good and the bad about the surgery and all the risks. So you have to accept the risks. And I'm not trying to belittle the surgery, because it is big surgery and there are potential risks and complications. So we have to go through that beforehand, but we'll do that in the clinic. We won't do that the day of the surgery. We'll go through that in the clinic. And so once you made the decision to have the surgery, I think the thing is to just, make you feel relaxed, try and be quite, conversant and jovial and friendly, and before you know it, you'll be asleep and it's all over. I mean, that's the thing. But it's hard, and I think everyone's anxious to a degree, and I think it is difficult if you do suffer from anxiety. And the other thing we can do is, maybe if you want to talk to the anaesthetist beforehand, sometimes people do that to find it helpful. But I mean, I think it's quite common, Tanisha, and we try our best to make you feel relaxed and at ease. Neil Robinson, hi, this is Donna. All right. Hi, this Donna. I was having mummy makeover on the Tuesday and it got cancelled on the Friday in March. With all this still going on, is it likely next year? I was having mummy on the Tuesday and it got cancelled on the Friday. Yeah. It got cancelled on the Friday. So, yes, so you're my patient and your surgery got cancelled. Is that what you're saying? Well, yes, it is. Yes, it is likely next year. I mean, we are doing surgery now. So, but the hospitals are far away, so maybe you don't want to travel. I hope they've offered you surgery, but if you don't want to travel, I understand that for this sort of surgery. So if you don't want to travel, that's fine. So will it be going ahead next year locally? Yes, almost certainly, but I can't guarantee it. The local hospitals are being used by the NHS. They've said the contract will end at the end of December. So they said they'll go back to normal in January. So I'm very much hoping that then we can start getting some normality. And if you've been cancelled since the beginning of lockdown, you'll be first of the queue, rest assured. And very much hoping that, yes, absolutely, we'll be getting back in January. And we are making plans. So I'll be honest with you, we are making plans. But we are a little bit restricted by the fact that the hospitals are saying to us, the contract ends at the end of December, which is like a couple of weeks. We need some dates, man. Give us some dates. But we haven't got dates, because we can give you a date and then you can relax. So I'd love to give you a date, but rest assured, I haven't given anyone any dates, because I haven't got any dates from the hospitals. But when I do, you are going to be first, my friend. So yes, really sorry. That's put the kibosh, isn't it? Waited a year for your surgery, but I haven't been to the surgery hospitals locally since March. I have not been there, so it's not like it's all going ahead. I have been to other hospitals, but they're far away. So definitely in the new year, we are making plans, and we just need some dates in the hospitals, and they've said that they will go back to normal, and we are crossing our fingers and toes. So hopefully we'll keep you updated, and I will see you very soon, Donna, and get this thing done. Because very keen to make sure that those patients have been waiting a long time get done. And I'm very sorry that this has happened, but the hospitals are all shut down. So Keely says that was helpful. That's good. Thank you, Keely. That's me. Good. Thank you. So Donna, watch this space. Or don't watch this space. We'll ring you. Or if you want, you ring us. Keep in touch. Yeah. Don't want you to feel like you're sort of not in the loop. I removed my daughter's wart of almost 2 years at home with wartner. Is that a person? Wartner? Was wartner helping you, or is a wartner a thing? Anyway, could you explain what's going on here? Is another wart likely to form? This is question 6. 1, 2, 3, 4, 5, 6. Okay, we've got a photo, guys. Okay, we have a photo. No. That's good. Okay, what is wartner? I don't know what wartner is. I'm assuming wartner, usually these sorts of wart things are salicylic acid. It's usually an ointment that you apply that destroys the wart. And you have to be careful to apply it just to the wart. This photo here, oh, sorry, Instagram. Can you see it? I don't know how good it is when I do this. Is it any good when I do that? Can you see it? Basically, this is a young girl's forehead, and there appears to be a wart on the forehead with a sort of red patch around it. And you have to be a bit careful when you're applying the wart treatments that you just put it on the wart, because if you put it on the skin around it, it can damage the skin. So that might have happened. I'm not quite sure what's happened here, because the skin around the wart looks a little bit damaged. So that could be a thing. You have to apply just the ointment to the wart itself. I'm assuming wartner is an ointment. I don't even know what wartner is, but I'm assuming it's the ointment that you put on warts. And so I think that might be what happened. Maybe a bit of ointment got around the side, or it's difficult because your child is 2, so your child might rub it, mightn't they, and then get it on the head. So that's a bit of a thing. We're not allowed to operate on children at the clinic, unfortunately, so we can't help you with that. But I think that's what's happened. That might be what happens if you had a wart there and then there's redness around it. I think the ointment has got onto the surrounding skin and sort of damaged that skin. I don't think it's a disaster, but I think you've got to be a bit careful, because the ointment should just go on the wart to destroy it, and you have to often keep on applying it and peeling it off and applying it to remove that wart to make it smaller. But it's difficult on a 2-year-old. It's difficult on a 2-year-old. So, do you do FDL upper back lift and vaser liposuction? What's the difference between vaser and normal liposuction? So FDL is fleur-de-lis, which is a type of tummy tuck where you have a vertical extension. So it's like a fleur-de-lis, like these people have on their shields. So yes, we do that. Upper back lift. Often I'd use liposuction rather than do a lift of the upper back, but yeah, we can do an upper back lift, but we'd have to have a look at that. An upper back lift will give you scars on your rib cage, and I would probably go liposuction there. But anyway, vaser, no. Vaser, we do power assisted liposuction, or liposuction basically is putting a metal tube underneath the skin and sucking the fat out. Basically, that's what liposuction is. And there are assisted forms of liposuction, so it can be assisted in some way. The most common one we use is power assisted, where the metal tube goes backwards and forwards. There are other types of assisted liposuction where energy is delivered to the fat before it is removed, and vaser is one of those. So vaser is one where it delivers ultrasound energy to the fat before it's removed. The benefits of that are that the fat is slightly liquefied before it's removed, so you can use a smaller cannula than you would for power-assisted liposuction. You can often do it when you're awake, whereas a normal liposuction you normally need to be asleep. And the other benefit is, because it delivers some energy to the fat, it might deliver some energy to the skin and cause some skin retraction. Now, the people who do vaser would, I think, say that. Now, I don't do vaser, so it's probably best to talk to a vaser person to get a balanced opinion on that, which is good for the skin retraction. So I often say to people, having the tummy and things like that, it's good that if it does cause skin retraction, it's good. Now, the worry is, it's like anything, whenever someone tells you something that's the best or that's good, you think, why doesn't everyone do it that way? Well, if it is delivering a heat energy to the skin, the worry is that I would worry that it can damage the skin. And certainly in the old days, and it might be going back a bit, and I might be old-fashioned saying this, but there was some cases with burning of the skin caused by that energy. And I think now they have temperature probes and things and safety measures to avoid that. But that is a worry for me. And if it is not giving energy to the skin, and that much energy to the skin, well, is it going to actually cause that much skin retraction? So It's a balance. They might say, "Oh no, it's not gonna cause skin retraction. It's not gonna cause burns to the skin. Of course not. It's not gonna give that much heat." Well, then, if it's not gonna give that much heat, is it gonna give enough to cause skin retraction? I don't know. Just saying. It's just Olivia's here. Evening, Olivia. Just saying. I'm not sure whether that how much skin retraction it gives, but that is the difference. And I think you can do a lot of things with power assisted liposuction and vaser liposuction. I'm not sure how much of a benefit it gives, and it's probably a question of looking at someone who does vaser to see whether there is significant benefits with it. But it's not something we do at the clinic. If you are looking for that. It's a long one. Are there different techniques for areolar reduction? What do you do? I've seen that some surgeons perform the surgery by taking away the excess areola in a teardrop shape and then stitching back up, leaving a lollipop type scar to prevent the areolar scar stretching and causing them to regain their preoperative size stroke shape. Is this common practice, or do different surgeons use different methods to prevent the areola regaining their original size? This is, of course, something I would want to avoid when I have this surgery. Wow. I've not seen an areola reduction giving a lollipop scar. A lollipop scar in my practice is a breast lift. So you can do that. You can remove extra skin. I mean, that's why there's more scarring. It's not to prevent, what is it, to prevent the scar stretching. So in my practice, you're absolutely right. There is a risk that the scar can stretch when you do an areola reduction, because you're taking a big circle around the areola and then a small circle, and you take a donut of skin and then you cinch it in. And so there's a risk, because that skin's under tension, that the scar can stretch. So you can, in my practice, the way I do it is I use a permanent suture to reduce that risk. Not everybody uses a permanent suture. Some people use a long-term dissolvable suture. The reason people don't use a permanent suture is because if there's any infection in that suture, or if you can feel the knot, or if the knot extrudes through the skin, that's always going to be there. So that's a problem. So there are, I accept there are risks with using a permanent suture, just like anything. If anyone tries to tell you that they do a technique that's all good and everyone else is doing it badly, or doing it wrong, you've got to think, hold on a minute, I don't think that's fair. So I think you've got to, full disclosure, there are bad things about using a permanent suture. But for me, the benefits outweigh the risks, because it reduces the risk of stretching, which is a worry you have if you use a permanent dissolvable suture. Although, as I say, dissolvable sutures can they are long-term dissolving sutures, so they take a while to dissolve, and the hope is it will form scar tissue in that time. The thing you're describing, where the lollipop lift, the lollipop scar, is more of a breast lift, which at the same time as a breast lift do form an areolar reduction. So an areolar reduction is an integral part of a breast lift, but it's a bigger operation where you're reshaping the whole breast rather than just the areola, and you're taking a lot more skin away, and that will give that lollipop scar. And it's I would argue, a different operation to an areolar reduction. It's something which you're globally reshaping the breast rather than just making the areola smaller. So I don't think, for me anyway, I think the different ways people do areola reduction is basically whether they use a dissolvable or permanent suture. Those are the two options, really. I think. I'm not sure if there are any other sort of techniques. And then the thing you're describing with the lollipop scar, I would then call a lift. And there are lots of different ways of doing a lift, of course. But I would call that a lift, which is a bigger operation to reshape the whole breast. Here we go. Olivia's got a question. Ask JJ hashtag. It's really hashtag Ask JJ, but we're not gonna split hairs. If the implant is under the muscle, can you feel it moving from the side? Can you feel what moving from the side? The implant. Yeah, you'll be able to feel the implant from the side if it's under the muscle. So the muscle's here. So you will feel. Can you see the muscle? The muscle's here. So you will feel the implant here. Feel it moving. So the thing that moves is the muscle. So when the pec contracts, sometimes the breast contracts because the implant's underneath the muscle. When you say feel it moving from the side, do you mean the implant or the muscle? Hashtag Ask JJ. You got it, Olivia. We get there in the end. Yeah. So can you feel? So you can sometimes you can feel the implant from the side. anyway, whether it's under or over the muscle. In fact, you can sometimes feel the muscle. The muscle doesn't hide the implant from the side. If this is, I hope this is answering your question, Olivia. The muscle just covers it here in the upper medial aspect of the breast. It doesn't cover it in the lower lateral aspect of the breast. So yes, you can feel the implant in the lower lateral aspect of the breast when it's under the muscle or when it's over the muscle. If you sort of squeeze it, yeah, if you squeeze it, you can feel the implant. Yeah. Oh, yeah. Well, good evening, Instagram, both of you, and good evening, Facebook. There's loads of people on Facebook. So I'm out of questions. So I'm going to say, hope all's well. I'm going to check myself out. If you've got any questions, please ask away and please post them and I will definitely answer them. Oh God, I just turned my TV off. Did that happen? Sorry. Oh God, I turned my TV off. So please feel free to email me, post on Facebook, post on Instagram if you've got any questions. I'll be here. Will I be here next week? Crikey. It's not Christmas yet, is it? That's the 22nd. Probably will be here next week. Is that an all day? Yeah, probably be here next week. So I'll see you same time, same place next week, I think. Unless I'm doing going to some crazy Christmas party or something, but we're not having those anymore, are we? So no, I will be here next week. Post them on Instagram, post them on Facebook. High five. High five, Jackie. Thank you, Jackie, staunch supporter. You're one of the two, Jackie. Yes, Jackie, you're doubling the numbers. Thank you. And I will see you here next week. I'm going to stop the stream.